Thanks for the invitation, and it's really my honor to join this meeting. And I miss the lives of traveling everywhere, but now what we can do is sit here and just talk to each other from the internet. Yes, and so before I start on my talk, I'll share you with one of my favorite websites telling us the information of coronavirus. And this website was called World Meter. And it has the updated data, and it's like this. So it will show every day the cases have occurred, new cases in every country in the world. And it used the color to represent the trend of virus infection in every country. And if it is the red line, it means that it is still in trouble. If it is blue, it means that it's already about to pass the plateau of infection. And it is green, it means that, oh, this country is going to pass the disaster. So which means that Russia is still doing very badly. And Spain is doing better now, and Germany is doing very well. And USA is still in the middle of the plateau. And also in a lot of countries like South Korea is doing very well. And I'm sorry that Japan is still rising quickly. So it still takes some while to settle down everything. And how about us? So it's like Hong Kong, Taiwan, Singapore, and Vietnam. Seems Hong Kong and Taiwan is doing quite well. We are so far. So we don't have a lot of cases so far, and we hope don't have more cases in the future as well. Yes, and I think that's the reason, because Hong Kong and Taiwan, we were all severe injured during the SARS. That's 2003. And after that, we learned a lot about this very terrible virus, the coronavirus. So, and all the leaders at that time still have power now. So they know how to deal with this kind of virus infection during this pandemic time. So in Taiwan, we have around 395 cases so far. And it's not a lot. It's, I mean, compared with many different sides of the world, is just a small number. And also most of the cases from the imported is from many countries outside who coming back to Taiwan. And unlike the SARS period, only 6 were confirmed cases were from the healthcare providers. So we are under very good protection so far by the government and by the hospital. So it's very good. Unlike the SARS during 2003, we had a lot of surgeons and doctors died during that period. But now, so far, it's not so bad. And also the mortality rate is 1%. And because we have a very good control so far, we have a very early border control. And our CDC, they start to check the airplane from last year, December 31, when they know that there are something in Wuhan, and they try to check the airplane from last year, but not this year. And also they set up a border control very early. So, and because this is our vice president, who is a very famous epidemiologist, and also the commander of the SARS, and now he became the vice president. So he set up a very good rule and also the leadership. So that's, so far we are doing not so bad so far, like Hong Kong. Yes. So in my hospital, we also have a very big capacity in Taiwan. It's around 10,000 beds. So we are mostly the hospital in charge of almost maybe 80% of the coronavirus infection in Taiwan. So we set up a very strong, strong rule in regulation and also the triage of the patients. So we set up something like this. So in a hospital, we set up a lot of triage points. We limited the exit from 20 to 4. And every patient should have a lot of inspection before they enter the hospital. And also we have a lot of different triage and different at entrance plot. And also the isolation area, the red and the blue, but red, green, and yellow. So it's something like this. So, and we also set up a very clear path for different color and different areas. Okay, and I'll skip this. And also for us, the surgeons, because surgeons are not the first line, are the second line. But our hospital asks us to separate into groups. So which means that, for example, my patient and me can only appear in such floor in my hospital. I can't go to other floors because in case someone got infected, we have the second team can doing something similarly. So we set up this team very early. It's around 2 months ago. We separate into different teams, but with same functions. So which means that once the 6A team disappeared, I mean, need to be isolated, and we have the 6B team can take over everything. And then for the 6C teams. And that's very important because when someone get infected and the whole team will maybe need to isolate it and quarantine. So that's very important. And also the staff, we have the app for every day to monitor our vitals. We have to key in input our vital sign every day, and they will record it by the system every day in case that there are something bad happen to the medical staffs. So we are under very strict and good protection under my hospital. So that's like the chart of every employee in our hospital and have the blood temperature monitor every day. Okay, and how about surgery? So so I think talking about surgery, so as Hongji just reported, the ISDE guideline for how to management of other upper GI endoscopy and surgery during the COVID-19 outbreak. So, and because I'm a thoracic surgeon, so we do both thoracic, I mean lung and esophagus, and I belong to both ISDE and also the ATS, or the AATS is from the American. So just several days ago, the ATS, they also published their guideline of how to manage the patients during the COVID-19 pandemic era. And so in the following slides, I will show you the ATS guideline because I know that Hongji and Philip will show everybody about ISD guideline. And actually they are very similar, very, very similar. So because I've read both of them, and I'll show you some important points, and then maybe we can have some discussion later as well. So first, they divide it into 3 phases. So first, as a surgeon, you should know what's the position of your hospital and the status of the COVID-19 in your country. So if your hospital has only few COVID-19 patients and the hospital resource is intact, which means that you still have plenty of ICU bed, ventilators, clinicians, and then so you can, surgery is not so restricted. That is the situation in my hospital now. So for esophageal cancer, you can do esophagectomy in patients with esophageal cancer, and that is you can do still as soon as possible. And for those who might be stay for a long ICU stay after surgery, for the high-risk patients, maybe you should wait for 3 months and then to do the surgery because that patient might occupy the ICU for a long time. And for the ESD, for ATS guidelines, they say maybe you should think about alternative treatment, and that I think we can discuss later. How about how to put the patient for ESD? Should we wait, or we can do as like in this column as soon as possible for the T1A and some T1B superficial patients? So in the second phase, maybe there are a lot of hospitals in Europe. I think is now in this phase. So they have many COVID-19 patients, and the resources is very limited. You have only small ICU bed and also ventilators. So for this, the surgery only reserved for one condition, that is the perforation of the cancer. So otherwise, everything should undergo alternative treatment. And also there is something very interesting. So it's like this, it's the neoadjuvant versus definitive chemoradiotherapy. And so in this, if you are in this phase, maybe you should consider for those you used to treat by neoadjuvant therapy, you can shift to definitive chemoradiotherapy and followed by self-surgery if the patient have evidence of persistent disease or recurrent disease. And because I think this virus pandemic time might be finished within the next 3 to 6 months. So maybe it's a good way to postpone some surgery patients, but also maintain a very good survival. And so, and this is another concept that is also very, being discussed is very prevalent now. So because in the past, neoadjuvant surgery, neoadjuvant CRT always followed by surgery. So there are some patients, they find that maybe surgery is not always needed. The scheduled surgery. So there are some trials that is going on in Europe that called the Chao trial. So surgeries as needed for the oral esophageal cancer. So they find that for patients who have good response, so which means that there is no residual cancer by biopsy, PET, and the CT, and perhaps you can let the patient withhold the surgery and followed by endoscope for every 3 months, and until you find evidence of residual cancer, and then you do the surgery. And that, from their preliminary result, it is very promising, and they can save around 80% of the esophagus, don't need the surgery, and survive. So in this, maybe this concept is still under investigation, but I think it's another way. If you are in phase 2 and you're facing this kind of patient, and you can postpone the surgery in this subgroup of patients. And in phase 3, that is only the preparation of cancer is the only surgical part, and other parts there is no indication for surgery. Okay, and finally, this is another very important part, that is the CO2. So during the surgery, when you need to put in the CO2, the CO2 pneumothorax or pneumoperitoneum, like for the esophagectomy, you need both. You need pneumoperitoneum and you need artificial pneumothorax. And there are a lot of things you need to keep in mind. Even the patient has maybe low risk of COVID-19, maybe, but you don't know. But you should protect yourself and also, your staffs and also all the OR staffs and nurses. So first, there are some tricks that pointed out by some papers and some researchers. So first, we should make the port incision as small as possible. And all this was to try to let not the CO2 out. And then you should use the lowest pressure as low as possible, but to keep a good acceptable field. And then you should let your partner, the anesthesia doctors, to maintain a very good deep neuromuscular block. Otherwise, when you do the surgery and the patient is, they are try to use the abdominal for breathing, and they will let the CO2 out very quickly. And also, you should minimize the leakage of CO2 through the trocars. And also, when you are using an ultrasonic device, please try to set the energy to the lowest level to minimize the smoke. And also, you can use some closed smoke evacuation device like the LCO system and other filter systems, and try to make it like the closed circulation system. And also, when you finish the surgery, don't let the CO2 rapid separation very quickly. You should slowly and don't let it out, and because that will put yourself and also your colleagues in danger. So, and that's all my part of the surgery part. And thank you.
Thank you very much, Ying. Very informative, important information. And I share with you that during the very early epidemics of the COVID-19, in fact, we did one thoracic surgery, worry about whether the patient is having any positive virus. And at that time, the COVID test is not commonly available. So what we did is we all wear N95 mask and performing the thoracic part for 4.5 hours, and it's really challenging. So my question about is that whether you actually would recommend that we shouldn't use any CO2 at all, because you mentioned a very important point, and there are some surgeons who actually say that we shouldn't do any laparoscopic surgery because of the risk of this gas leak. So during the insufflation, maybe we should all change it to open. What will be your opinion?
Actually, I've read some guidelines from the gynecologist and also the general surgeons. So from all these guidelines, I think they all recommend laparotomy, but not laparoscopy. And I think that's reasonable. I think we should minimize the use of CO2 if the patient has highly suspicious or even suspicious of the infection. And also one thing for the chest, so how do you manage the chest tube after surgery? Do you still put the closed drain or open drain, or do you underwater seal? And how do you minimize, because so what's your policy for putting a chest tube in that patient? Do you use a closed drain or open drain, or putting some filter in your drain system? So Philip, what did you do for that patient?
Yeah, I think we generally just put in like a closed system, no suction. But well, that is our usual practice for esophagectomy. But I know that some thoracic surgeons always do a suction, positive suction. Yeah. So I guess there may also be some risk if the patient turn up with a COVID positive patient. Theoretically, you know, if a positive suction in the circuit, you may actually spread the virus.
Yes, if the patient has some pleural adhesion during the surgery, and you need to do some pleuralysis, and that will also keep let us in danger, right? So we have to be very careful. Yes, because esophageectomy is a field that you have both the neck and the chest and the abdomen, and we should be very careful, and also high risk and a longer ICU stay. So that will occupy the hospital resource. So we should be reconsider to do surgery in very, moderate or low risk patients, but not for high risk patients at this moment. That's my suggestion.
Thank you very much.